Well, welcome everybody to the first session of this GVHD Interactive Provider Network. The topic of this session is going to be treatment decisions in chronic graft versus host disease. My name is Stephanie Lee. I'm at the Fred Hutchinson Cancer Center, and I'm joined by our presenter, Dr. Zach DeFilipp. He's the director of the bone marrow transplant clinical research at Massachusetts General Hospital and an assistant professor at Harvard Medical School. We're also joined by our case presenter, Dr. Richard Newcomb. He's a hematology oncology fellow at MGH. This program is supported by a grant provided by Insight Corporation through the Insight Ingenuity Award. So the goal of this GVHD Interactive Provider Network is to connect GVHD specialists with community providers with the goal of sharing expertise, discussing cases, and then improving patient care. So here is the program agenda. After my brief introduction, I'll introduce Dr. DeFilipp, who will give a didactic presentation. We'll then move into our case presentation by Dr. Newcomb, and hopefully the case will illustrate the principles that you've just heard about. After that, there will be Q&A and panel discussion and some closing announcements, but please feel free to put questions into the chat or to raise your hand at any point if you'd like to ask a question. So the educational objectives are to determine when to change therapy for chronic graft versus host disease, to review novel agents for treating chronic GVHD, and to discuss options for managing chronic GVHD flares. Here are the faculty disclosures. Our overall chair and planner is Dr. Steve Pavletic, and he has no disclosures. Mine are listed there, and I'll just give you a moment to look those over. And here are the disclosures for the other presenters. All relevant financial relationships for this activity have been mitigated. This program is put on by the Aplastic Anemia and MDS International Foundation, and great thanks to them for this work in beginning this series and organizing everything. So just some housekeeping issues. For educational and quality improvement purposes, we will be recording this video session. By participating in this program, you are consenting to be recorded, and we appreciate and value your participation. And if you have any questions or concerns, you can email gvhdnetwork@aamds.org. So some helpful tips for participating in this ECHO program. First, we encourage you to keep your camera on during the program. Please mute your microphone when you're not speaking. That's in the left bottom corner of your screen. To ask a comment, to make a comment or ask a question, please raise your hand on camera or use the raised hand icon in the reaction section at the bottom of your screen, and I'll call on you. And please clearly state your name, institution, or practice before stating your question or comment. And you may also use the chat function to submit comments or questions. So with that, I'll take my slides down and introduce Dr. DeFilipp, who will be putting his slides up and starting the didactic portion.
Just get off mute there and share my slides. All right, this looks good. Everybody can see the slides?
Yep, looks good, and we can hear you. Thank you.
Great, thank you. So thank you, Stephanie, for the introduction. I want to thank everyone for the opportunity to be here today to talk a little bit about how we make treatment decisions in chronic graft versus host disease. As was talked about in the introduction, I'm first going to go through some slides overviewing chronic GVHD, but really focusing on some of the newer agents that are now available for use in the clinic and how we maybe think about using these agents and how we implement them into our clinical practice and taking care of patients. And then we'll go into a clinical case that will help illustrate some of these ideas. So I think, as probably many people are familiar with, chronic graft versus host disease is one of the leading complications that happens in patients who receive allogeneic transplants. And it is a driver of long-term morbidity and mortality in this patient population. Most generally, when we talk to patients about chronic graft versus host disease, it's always important to emphasize kind of in more lay terms what's going on, because it can be very complicated for patients to understand. But the general principle is that the donated cells, the graft that they have received as a potentially curative treatment for their underlying disease, there's disparity between those donated cells and the patient's host tissues. And this can lead to a situation where the donated cells end up attacking and causing damage in the recipient, and thus leads to graft-versus-host disease. Chronic graft-versus-host disease is a form that usually happens a little bit later after transplant, as we'll talk about, but it is pretty common. It's anywhere from 30 to 50% of patients will develop some form of chronic graft-versus-host disease, but that number really depends on a number of different types of variables to be considered. What type of donor was the transplant done from? What was the graft source, and also what type of graft-versus-host disease prophylaxis medications were used. So this is just a illustration showing the incidence and maybe a little bit of the difference between acute and chronic graft-versus-host disease. So there is a form of graft-versus-host disease that happens early on after, typically more early on after transplant, called acute graft-versus-host disease, which is characterized by a skin rash, certain GI symptoms, or liver inflammation. And you can see that typically it happens before day 100, though that is not a hard time point for diagnosis, but typically happens in the earlier months after the transplant. Today, we're really going to be focusing more on chronic graft-versus-host disease, which typically, as you can see from this illustration, happens more later on after transplant, either in the months or even in the years after transplant, and has a number of different, some overlapping, but also some unique disease manifestations. So really, almost every organ system can be affected by chronic graft-versus-host disease. Classically, we kind of think about the skin, the mouth, and the eyes being three of the manifestations that are more common, but also, the nails, the hair, both the upper and lower GI tract, the liver, the lungs, the muscles, and the joints can all be affected. And this picture is from a nice review in the New England Journal of Medicine a few years ago now, just highlighting what some of these more advanced manifestations may look like on clinical exam. We do have pretty standard ways to assess chronic graft-versus-host disease now. So there have been numerous now meetings of the NIH Consensus Conference in 2005, 2014, and more recently in 2020. And these earlier conferences really helped kind of establish a diagnosis and grading criteria where each organ is assigned a severity score, and then looking at the different number of organs involved and their severity, you can get a global severity score for the chronic graft-versus-host disease. And this is just kind of a summary of how that final score looks. So mild chronic graft-versus-host disease is when there's only one or two organs that are involved, but usually with a more mild manifestation, meaning a score of 1. If there are three or more organs involved with mild involvement, or you have at least one organ that has more, at least moderate involvement, that will upgrade the overall severity to moderate. And severe is when you're seeing severe manifestations, with one exception being that the lung, because of the morbidity that is associated with lung graft-versus-host disease, it carries a little more weight. So we've accomplished a lot as a community in the treatment and diagnosis and understanding of chronic graft-versus-host disease. So we have well-characterized disease manifestations, and we have standardized assessments for both organ involvement as well as treatment response. And we have worked to better understand why chronic graft-versus-host disease occurs biologically, as this is a review article from that same publication showing that there are numerous pathways that can contribute to the development of chronic graft-versus-host disease. And understanding these pathophysiological mechanisms has allowed us to develop therapeutic agents and bring them into clinic And I think that we as a community are very proud of the fact that we have gone in the last 5 or 6 years from having no FDA-approved therapeutic agents to now 3 FDA-approved therapeutic agents. And I want to kind of talk a little bit about those in more detail because they are starting to become used more frequently in clinical practice. Despite these accomplishments, we do have certain challenges that still exist. One thing that has not changed is that it's very difficult to achieve complete responses with this type of disease. As the terminology chronic implies, these patients, although they may improve and get benefit from treatment, many of them deal with their GVHD symptoms for many, many months and sometimes years, and they have ongoing disease. And there's a lot of heterogeneity in what is termed a partial response. If a patient starts a treatment and gets a little bit of improvement, that would be considered a partial response. Another patient may get much more meaningful clinical improvement, but if their symptoms are not completely gone, it's still considered a partial response. And I think for us as investigators, that gets hard to tease out sometimes when we're evaluating clinical data. We need agents that provide durable responses given the length of this disease, and we need to figure out how to better integrate these new therapeutic agents that we now have access to. So we're thinking about frontline therapy in chronic graft-versus-host disease. I think it's important to know and remember that when a patient initially presents, they often present with more mild symptoms at first, if you catch it early. And some of those mild manifestations may initially be closely monitored without intervention, or they could be addressed with local therapies. So I think some of those more common organs and involvements, either the skin, the mouth, and the eyes, are perfect examples where different types of eye drops, mouth rinses, or topical creams may be used initially before needing to use systemic therapies. However, if one of these organs manifestations becomes more advanced, or there are more organs involved, it usually requires some form of systemic therapy, usually an oral agent, as many of these patients are outpatient. The first line of systemic treatment in chronic graft-versus-host disease has been and continues to be corticosteroids. But what we know is that corticosteroids may get an initial response, but most patients that develop chronic GVHD that need systemic treatment end up needing additional lines of therapy. So these failure-free survival curves are here to illustrate the fact that, within the first few years of being started on treatment, either as initial therapy for chronic graft-versus-host disease or even as a second-line treatment for chronic graft-versus-host disease, as you can see here in the black, a large majority of patients will end up requiring another agent. The NCCN guidelines kind of reviews a number of different agents that have been studied and shows potential benefit for patients with chronic graft-versus-host disease. But as you can see here, it can be a little bit daunting to kind of think through which of these agents might be most appropriate to use. I'm going to focus now talking just a little more about the FDA-approved agents that have come into clinic in recent years. So ibrutinib is an agent that is an oral Bruton tyrosine kinase inhibitor and is familiar to many people because it is FDA approved for the treatment of lymphoma. But there is strong biologic rationale for its use in chronic graft-versus-host disease because one of the things that we learned in the last decade is that it's not only T cells that are involved in graft-versus-host disease, but also specifically in the chronic form of the disease, B cell signaling is very important. So this agent, ibrutinib, it inhibits B cell signaling and also some other pathways and has shown responses in preclinical models. This led to a very important study. This was a phase 1b/2 trial in 42 patients that had failed 1 to 3 prior therapies of chronic graft-versus-host disease, and these patients were enrolled to receive ibrutinib in the treatment of their disease. Interestingly, one caveat about this study is that it did require at least one inflammatory manifestation of disease. So patients either had to have a skin rash or they had to have more involved oral manifestations, with trying to test the hypothesis as to whether this agent would have a treatment effect, and that you might be able to see that more quickly with some of these inflammatory disease manifestations. So patients received a dose of 420 milligrams daily, and with that, the best overall response was 67%. And I think it's very important to point out here that compared to some of the other studies, we'll see that the number of complete responses in green was higher than what was seen in some of the other studies, but that might be somewhat due to this kind of unique eligibility criteria of having an inflammatory disease manifestation. In addition, these responses that patients experienced were sustained, and people were able to see maintenance of their response over a longer period of time. So this data was the foundation for the FDA approval of ibrutinib, which has now become used with more frequency in clinical practice. More recently, we've had the FDA approval for ibrutinib was back in 2017. The next two FDA approvals were just within the last year in 2021. The next agent is belumosudil or Rezurock. It has a unique mechanism of action. It's a ROCK2 inhibitor. So it inhibits this Rho-associated coiled coil-containing protein kinase 2. And the rationale for its use in chronic graft-versus-host disease is that it can kind of shift the balance of Th17 cells and T regulatory cells, which can have a favorable effect in chronic graft-versus-host disease. And I think at least potentially important in the chronic graft-versus-host disease setting is that it has the potential to inhibit multiple pro-fibrotic pathways. As we know that chronic graft-versus-host disease, some of the most challenging organ manifestations are those that have fibrosis, and I think that there's a lot of interest in this agent in that setting. There was an earlier phase 2A dose-finding study that found that the overall response rate for patients receiving belumosudil was about 65%, and this was over. You could see this response, despite what their previous lines of therapy were or the severity of their GVHD. This led to a much larger study, a randomized phase 2 study with 132 subjects who were a little more heavily pretreated, right, 2 to 5 lines of treatment prior to enrollment. And the overall response rate, whether they received the dosing once a day or twice a day, was 74 or 77%. These figures here show that the responses were seen across a lot of important subgroups of patients based on treatment history, severity, number of organs involved, and previous therapies that were including previous ibrutinib and ruxolitinib exposure. And the bottom figure here shows that manifestations were seen across a number of different organs. So belumosudil became FDA approved based on this data, and was just, and that occurred last summer, so still a relatively new agent in our clinical practice. Finally, I want to talk a little bit about ruxolitinib. It's an oral selective inhibitor of JAK1 and JAK2. It's familiar to many people in the transplant setting because it's already a FDA-approved agent for the treatment of steroid-refractory acute graft-versus-host disease, and also familiar to many because of its previous FDA approvals in myelofibrosis and polycythemia vera. The rationale in chronic graft-versus-host disease, once again, is that it has probably its strongest effect by decreasing pro-inflammatory cytokines, which can really drive disease manifestations in this patient population. A very important trial that was published in the last year was the REACH3 trial. So it's a randomized phase 3 trial where patients who had steroid refractory or steroid dependent chronic graft-versus-host disease were randomized either to receive ruxolitinib or a best available therapy, which was consisted of a number of common choices that are available to patients, but usually none with an FDA approval. You can see here that the best overall response rate was better with ruxolitinib, 76% versus 60%, with higher rates of both complete responses and partial responses. And when looking at the failure-free survival curve, patients who were on ruxolitinib were able to maintain on that treatment for a longer period of time than what was seen with some of the other agents. So when thinking about, as a summary of these trials, these trials are unique. None of them were made to really compare to each other when thinking about these three agents, and there are caveats to each of these studies to think about when thinking about which agent to use in our clinical practice. So the ibrutinib study was small, and we talked about how the patients either had to have a rash or a mouth score, how applicable that is to all of our patients is questionable. Depends on what the manifestations are that you're seeing in clinic. But compared to these other studies, the complete response rate was 21%, where it's usually been 10% or less in some of these other larger studies. The ruxolitinib study probably has the strongest trial design because it's a randomized phase 3. You're actually comparing ruxolitinib to non-ruxolitinib interventions. But it was really only after one line of therapy. Those patients had only really received corticosteroids. Belumosudil is maybe better equipped to address the patients that we often see in clinic who have received multiple lines of therapy and are looking for a new agent, as it was tested in patients who were more heavily pretreated. Just a few things about the FDA approvals when looking at the specific wording based on the trial design. So ibrutinib is in adult patients only. And after, for chronic graft-versus-host disease that had failed one or more lines of treatment, belumosudil and ruxolitinib are both FDA approved for adult patients or pediatric patients that are 12 years or older, with the differences really falling into the lines of therapy. So ruxolitinib is after failure of 1 or 2 lines of therapy, where belumosudil is after 2 lines of therapy. So saying that we can't compare these agents head to head, another thing to consider when making treatment decisions are key toxicity considerations. So, are there any things that I need to know or think about with these agents that might make me want to either maybe avoid that agent in a specific patient that we're seeing in clinic? So ibrutinib can be seen to have fatigue, muscle pain, and edema. It's also known to have a risk for arrhythmias, though that really hasn't played out in the transplant setting as much as it has in the lymphoma setting. Belumosudil can be associated with elevated liver function tests, and ruxolitinib, I think most importantly, can be associated with cytopenia. So a good example I bring is if you have a patient who's already has cytopenia issues, they're either anemic or thrombocytopenic, you may want to consider an agent that's not ruxolitinib, or maybe ruxolitinib at a lower dose to try to account for that specific issue. So this is my current approach to patients with chronic graft-versus-host disease. So in the frontline setting, if I have a clinical trial that is open and the patient meets criteria, I would enroll in a clinical trial. If not, I do just initially treat with systemic corticosteroids. The starting dose, is usually around 1 milligram per kilogram, usually not higher, but sometimes lower depending on what the manifestation is, and also any other comorbidities I have to consider in the patient. Beyond that frontline treatment, once again, if a clinical trial is available, I like to try to see what we can learn and maybe provide for the patient in that context. If not, I usually am now reaching for one of these FDA-approved agents. Practically, the choice of agent comes down to a little bit of clinician preference and experience with these said agents, and also toxicity considerations. One thing that comes up is, do you use multiple of these target agents at the same time? Initially, I had not been doing that, but I will say that in the recent months, I've kind of leaned towards that. I think the scenario in which I consider using multiple agents at the same time is a situation where the patient has received one of these agents and has demonstrated some clinical benefit, some form of a partial response, but they have ongoing symptoms that you feel need an additional layer of treatment. In that setting, I would potentially use 2 agents at the same time. If a patient clearly progresses on one of these agents or is non-responding, then I would not continue multiple agents together. Also, for sclerotic manifestations, those are still quite challenging, even with these newer agents. And I do consider using ECP or photophoresis in these patients a little bit earlier than I would if there were no sclerotic manifestations. So when thinking about future directions, one question is there an ideal sequence to these systemic agents in the treatment of chronic graft-versus-host disease? And that's really, I don't know if we're ever really going to know that answer. It would require certain types of clinical trials that I think are going to be hard to conduct. So we're always going to be in a situation where we may have multiple options, and clinicians will have to kind of start to parse through their personal experience with real-world use of these agents to see what might work best for them. Another question is, can they be used concurrently? So we already talked about that a little bit without significantly increasing toxicities. And I will say in the patients that I've used, maybe it's because we're using one agent and then I'm adding another agent on top of that. I've not seen a real toxicity signal, but that might be a little bit different if both agents were started at the same time. So these are some things to kind of consider. Ideally, we would love a way to predict whether a patient would be more likely to respond to a specific agent, whether this was like a clinical phenotype or some type of biomarker, but I don't think at this point there's anything on the horizon we really have to be able to use clinically yet for that type of individualized care. And then the other question will be, will using these agents in the front line setting maybe improve outcomes? So do we always have to first start with steroids and wait for steroids either to fail before adding another agent? Or is there a combination of agents or a specific agent that can be used earlier on, maybe improve the symptoms and be able to get an early response that avoids these patients with more sclerotic and long-lasting disease that are most challenging. So in summary, we have a number of advances in our understanding of chronic graft-versus-host disease that's led to new therapeutic agents, and the treatments landscape has shifted in the last few years with these FDA-approved agents, but that leaves us with probably more questions than answers on how to integrate these agents into clinical practice, and additional research is needed to develop new agents and also new approaches to chronic graft-versus-host disease. So now I think we're going to move forward with the case presentation. So myself and Dr. Newcomb will kind of go through this case presentation of a patient with chronic graft-versus-host disease. And there are going to be a few times that we will stop the presentation to kind of talk about the approach to the patient at different time points. And at those time points, specifically, if there are any questions that come in, whether you want to voice them directly or enter them in the chat, we'd be happy to kind of address those as we go. So Dr. Newcomb, I will advance the slides.
And just before we get started, I think that despite what we said, we can't really see you or see the hand raises. So why don't everybody put their questions in the chat, and that way we know we'll see them. So thanks, Dr. Newcomb.
Thank you, Dr. Lee. So we have a 61-year-old woman diagnosed with myelodysplastic syndrome in the fall of 2015. She experienced 2 to 3 months of worsening fatigue. A CBC showed pancytopenia. A bone marrow biopsy revealed myelodysplastic syndrome with excess blasts. She was subsequently treated with 4 cycles of decitabine with improvement of her bone marrow blasts and her peripheral blood counts. Due to the response in therapy, she underwent allogeneic hematopoietic cell transplantation in January of 2016. She had an HLA-matched unrelated donor. She received reduced intensity fludarabine and melphalan conditioning. The graft source was peripheral blood stem cells and received tacrolimus and methotrexate for GVHD prophylaxis. Her early post-transplant course, she had confirmed donor engraftment with no evidence of residual MDS. She had CMV reactivation, which was treated with valganciclovir to resolution. And she had grade 2, stage 3 skin, acute GVHD, which resolved with prednisone. Next slide. Now, 15 months later, she presents to clinic with a few new findings, including new and subsequently worsening rash in the skin, mainly to the face, slowly progressive dryness of the eyes, buccal mucosa with reticulation on exam that was associated with mild oral dryness. She had no shortness of breath, joint, or muscle pains, normal range of motion on exam, and her LFTs were within normal limits. At this stage, she was still on low-dose tacrolimus at 0.5 milligrams BID. So the question to Dr. DeFilipp is, what is your clinical approach to this patient at this point in time?
Yeah, so this presentation is pretty classic for what I think we see in clinic. I think one of the things that happens often is that these patients who are presenting with new chronic graft-versus-host disease, their symptoms are often mild and maybe a little bit hard to pick up on at once, as you might imagine. This patient, the entire picture is a little more convincing of chronic graft-versus-host disease for a few reasons that I'll talk about in a second. But if the patient had any one of these manifestations alone, it may be a little bit hard to tease that out. When thinking about this patient's, risk for chronic graft-versus-host disease, a few things to kind of consider. So she did have a transplant with the use of peripheral blood stem cells, and there are studies that have shown that patients who receive a stem cell graft that is peripheral blood stem cells, as compared to bone marrow, have a little bit of a higher risk for graft-versus-host disease. So that's one thing to consider. Another thing to consider, she had previous acute graft-versus-host disease, and patients who develop acute graft-versus-host disease are often a little more likely to develop chronic graft-versus-host disease a little bit later on, even if their acute graft-versus-host disease symptoms completely resolve. Also, the timing post-transplant is appropriate, right? The 15-month period after transplant is when is a classic time when you would see chronic graft-versus-host disease manifestations. In this setting, this patient happens to have 3 manifestations that we may be able to treat locally, as we alluded to before. So often when there is a form of a skin rash, especially if it's more localized and not more widespread, we will use different types of topical creams, usually different types of topical steroid creams. And that's what I would probably use to this patient's skin rash on the face. The slowly progressive dryness of the eyes, we usually start these patients at very baseline with some artificial tears, but we also have we have a pretty regimented post-transplant approach of having all patients be seen by one of our ophthalmology groups to have assessments for GVHD manifestations in the eyes, and they help a lot with a lot of different interventions beyond drops, cauterization and punctal plugs and other types of things that can be done for patients depending on the severity of their ocular GVHD. And although she doesn't really have limitation in her oral intake, but just maybe a little bit of mild oral dryness, kind of the reticulation that we see in her mouth is pretty classic in this setting for chronic graft-versus-host disease. And I would probably start her on an oral dexamethasone rinse that she would rinse and spit to try to see if we can get some improvement in her mouth. Based on the manifestations as is, I don't think that you have to start steroids systemic steroids in this case. You could start with the local therapies and see how things go and watch the patient closely. The other thing that I wanted to bring up here was the patient being on about 0.5 milligram of tacrolimus twice a day. And the question is should we increase the tacrolimus in this setting? I don't think there's a clear answer to that. In my clinical practice, I've usually not done that, though I do know of colleagues who sometimes may increase the dose of tacrolimus to see if that provides a little bit of systemic boost to these patients who are starting to develop new symptoms.
So we don't have any questions at this point, but I'll ask you a question if that's okay.
Go for it.
So this patient was transplanted for high-risk MDS. And so I wonder, this is kind of on the borderline. Do you factor the disease and the disease risk into your thinking about when to start someone on systemic therapy?
I mean, in my practice, I think that the underlying disease probably doesn't play as much of a there are certain studies that have associated the development of chronic graft-versus-host disease with a better GVL effect, meaning that these patients might have a little bit of a lower risk of relapse in the long term. But typically in these settings, when the patient's starting to develop disease that is heading towards needing treatment, I kind of, it's a little bit more agnostic to the underlying diagnosis.
Yeah, I think that's our practice here as well. If they need systemic treatment, I think they need it. We have seen some cases where people don't want to start anything, and then the patients end up in real trouble. This is a borderline situation, I agree at this point, but I think that the teaching point to the audience is that if someone does need systemic treatment, then you should go ahead and start them and not wait just because you're worried about abrogating the GVL effect. Thanks.
So she was treated very similarly to as Dr. DeFilipp suggested, with initial treatment consisting of tacrolimus 0.5 milligrams BID, so no change to the dose. She received hydrocortisone for her face, GVHD, artificial tears 4 to 6 times per day was suggested, and tear duct cauterization was pursued with the help of our ophthalmology colleagues. She also received an oral dexamethasone swish and spit 2 to 4 times daily. Unfortunately, within 1 month, she experienced worsening of her rash with her face, and there was actually spread to the arms. So at this point, Dr. DeFilipp, what would be your next step in the patient's GVHD therapy?
Yeah, so at this point, with the skin kind of not really responding to topical therapies, and beyond not responding to the face, but now starting to spread also to the arms, this would be a situation where I believe systemic therapy would be warranted. When we start systemic therapy for chronic graft-versus-host disease, we're talking about corticosteroids outside the context of a clinical trial. The starting dose typically is around 1 milligram per kilogram, but I would say that as I think I alluded to before, you have to kind of consider I think patient age and other kind of comorbidities into that starting dose. One thing I think we've seen is that in recent decades, we are now transplanting older patients than we historically have. And older patients, especially when they develop chronic graft-versus-host disease, don't always tolerate high doses of steroids, especially for longer periods of time. In some ways, I feel like when transplanting older patients, I think a lot of people question about the ability to get them through the early transplant phase of the conditioning and the hospitalization. I actually am much more worried about, later on when they develop a long-standing chronic graft-versus-host disease, how to kind of get them through that with the challenges of what steroids can do for them. So in a patient, though, that's maybe a little hardier, a little younger, I would still try to start about 1 milligram per kilogram of steroids to begin with. Some of these topical therapies or localized therapies can continue at the same time. I think within 1 month would be a little bit quick to think that you were going to see a huge difference in the ocular GVHD. But those things are not, can still continue on with systemic therapy at the same time. When starting steroids, you also have to consider some of the other supportive treatments that might be needed. So when patients are on higher doses of steroids, we typically put patients on a PPI to decrease the risk of steroid-induced gastritis and other GI symptoms. Another thing to consider is any infectious prophylaxis that might need to be changed. So, this patient's on tacrolimus, and in our clinical practice, all of our patients who are on tacrolimus remain on PCP prophylaxis of some sort. So although not stated, this patient's already on PCP prophylaxis, but the question becomes, does she need to be on fluconazole or some other type of antifungal agent? When starting a dose of 1 milligram per kilogram, I think the answer is yes. I would say maybe for lower doses, maybe not so much. And the other thing just to remember, anytime you add an antifungal agent, is just being aware of different drug-drug interactions. So fluconazole will effectively increase the therapeutic level of the tacrolimus. So even if we don't increase her tacrolimus dosing by adding fluconazole, effectively, we're probably getting a little bit of a higher therapeutic effect from the tacrolimus as well.
So again, I don't see any questions, but Mr. DeFilipp, so let's say this is a younger person and you went ahead and started 1 milligram per kilogram. When would you do your first taper? Is it based on their response? Is it based on time? Sort of what's the average time until you would taper?
So I think one thing that's ends up being a practical consideration with tapering is that we tend to taper in nice intervals of how the medication is provided. And we also taper usually on schedules of when we typically see these patients in clinic. So these patients, a patient like this is going to be outpatient, and around the time of a new diagnosis of chronic GVHD that needs new systemic therapy, I would say this patient should probably be seen on a weekly basis, even if up until now they have not, sometimes maybe every other week. It depends on how local they are. Now in the setting of remote visits, there may be ways to kind of do some virtual ones if traveling to the center is a little more burdensome. I typically would leave them on 1 milligram per kilogram for at least 1 to 2 weeks to see what it's in the setting of what their response is. If they're having a quick response to treatment, I try to taper them a little more quickly. My personal belief is that we start at a high dose. So let's say this patient is getting started on 60 milligrams of prednisone. And they start to, and they're responding. I think that we could probably taper them pretty quickly, let's say like over a month, down to about 20 milligrams of prednisone or so. But then I kind of slow the taper down after that, because I think that after you get that initial bang for the buck in response, probably have to go a little bit slower towards the end just to try to spare some of the steroid exposure. If the patient's either having side effects, the flip side is if they're not really responding, they're having a lot of side effects, you may want to taper them quickly as well, because they may not be really responding or getting that much benefit, and it might be time to move on to another agent kind of sooner than later. I think what we've seen, what's come out before in talking and even trying to analyze clinician practices is I think we all think that we taper steroids faster than we actually do. And I think I try to be conscientious of getting them off the higher doses of steroids a little more quickly if I can.
Thank you. We actually do have a question from the audience, from Dr. Schultz. How important do you think Tregs are in controlling chronic GVHD? Because tacrolimus suppresses T regulatory cells.
I think it is important. I think that a lot of the data that's come out recently with some of these newer agents has further emphasized the role of Tregs, and that inhibition of Tregs may not be beneficial for these patients. At the same time, I think there are a lot of people who clinically feel that having a little bit of tacrolimus or CNI on board may yet be a stabilizing factor for these patients. So that's kind of where my feeling is. If this patient was not on tacrolimus, if they had fully tapered off, I would not have restarted them. The other thing is that if I see they're having response to other agents, one of the first agents, after getting the steroids down to a more reasonable level, I do try to get the tacrolimus further tapered or tapered all the way off.
Great, thank you. Dr. Newcomb, do you want to continue with the case?
Absolutely. So she was started on prednisone, 60 milligrams, 1 milligram per kilogram, and was concurrently started on omeprazole and fluconazole. And as Dr. DeFilipp mentioned, was already on PJP prophylaxis. After 3 months on prednisone, the current dose, she had been able to be tapered to 20 milligrams daily. She remained with ongoing chronic GVHD of the skin, eyes, and mouth, graded as an overall partial response. Was starting to experience side effects, namely insomnia and weight gain. So Dr. DeFilipp, at this point, how would you approach the patient's GVHD therapy?
Yeah, so this is, This is once again, a common scenario in what I see in clinical practice. As much as we are adverse to steroids, one of the reasons that they are still an integral part to the treatment of GVHD is that they are able to elicit disease responses, especially early on. And that's what this patient has experienced, being one of these patients who falls in the category of partial response, but at the same time, now kind of building up some of the more side effects and complications from the steroid therapy. So this is a scenario where I would, without even seeing a flare of her disease, I would be looking to add another agent for two purposes. One, this patient, she still has ongoing GVHD symptoms that I would like to see if we can improve. So maybe from a kind of biological perspective, addressing the disease with a different mechanism of action would be beneficial. And then also practically, if that second agent allows me to further taper the steroid dose down and spare her some of these side effects, that would be good as well. The question is what agent to use in this patient in this setting. As we talked about before, there are many, and they're not compared head to head, so there's not a right or wrong answer here, except I would say that the two that fit the FDA approval would be either ibrutinib or ruxolitinib, as belumosudil would be for kind of more refractory disease, or more, at least 2 lines of systemic therapy when she's only received once. Based on the REACH3 trial, I would probably use ruxolitinib in this scenario in 2022. But as this is a little bit of an older case, we can kind of see where the case goes from here.
All right, perfect. So she was started on ibrutinib, now in combination with prednisone and tacrolimus. Over the next 6 months, she experienced further improvement, although not complete resolution in her chronic GVHD manifestations, and was able to taper off steroids completely. She was maintained on ibrutinib and tacrolimus for another 8 months until she began to develop sclerotic changes in the skin and fascia, mainly in her legs and arms. What is your approach to this patient's GVHD therapy now?
So, what I would first say is that I think this patient got a very nice response to the addition of ibrutinib. I think that when we're thinking about patients who have more long-lasting chronic graft-versus-host disease, and we think about these failure-free survival curves and what they may look like, a patient who's able to stay on a drug for a number of months and experience disease response. She was able to taper off the steroids, which was a concern clinically for her. These are all good accomplishments, but unfortunately, she really is now developing more concerning fibrotic and sclerotic manifestations in the skin and the fascia, and definitely needs a different line of therapy here. In this setting, I would probably discontinue the ibrutinib because it's probably at this point not adding as much benefit now that she has this kind of worsening disease. And in this scenario, there are multiple options, right? This would be a scenario where ruxolitinib would be an option. This is a scenario where belumosudil would be an option. And some people may tend towards belumosudil if because of that potential anti-fibrotic mechanism of action biologically, although I don't know that we've yet seen data that shows that 100% clinically yet. The other option to consider would be ECP. So to use photopheresis in these patients with fibrotic or sclerotic disease is something where I have seen good responses despite progression with other oral agents. I think the biggest limitation there is patients, it's just labor intensive. Patients typically need venous access. They have to go for half-day sessions of ECP either twice a week or once a week. And not everybody, depending on everything else that's going on in their life, is able to commit to that or wants to commit to that. So as much as I might ideally think about adding ECP earlier on, practically, I found we use ECP when we've have kind of exhausted some of the other oral, more convenient options for these patients.
Great. And so she was enrolled in a clinical trial with belumosudil, and she was treated for 6 months on trial. She tolerated treatment well and was taken off treatment due to progression of sclerotic disease. So now that she's had progression on the ROCK inhibitor, what is your approach to this patient's GVHD therapy? And I also believe there might have been a question in the chat from the prior slide. I'm not sure.
I think we can address the question at the very end. We have about 5 minutes left. So Zach, do you want to do this one? And then we'll go back to the question.
Yeah, sure. So, this patient went on belumosudil in the context of the clinical trial at that time. As we talked about before, in my practice, if I do have availability to a clinical trial, I usually will encourage patients to enroll. And the patient tolerated the treatment well, but now has kind of further sclerotic disease. So she's still naive to ruxolitinib. She's still naive to ECP. And for the reasons that we talked before, I'd probably offer her to go on ruxolitinib while stopping belumosudil before going on to try ECP.
Thank you.
And I think there's one last slide. Maybe you finish that up and then address any other questions. So.
Perfect. So she was treated with ruxolitinib, and after limited improvement in sclerotic symptoms with 3 months of therapy, she was started on ECP, for which she continued on for about 1 year with partial response that basically plateaued after 6 months. She was subsequently tapered off ECP and ruxolitinib with stable symptoms, and she's now enrolled in a clinical trial investigating axatilimab for ongoing GVHD symptoms.
Thank you. Thanks very much, Dr. DeFilipp and Dr. Newcomb. So the question in the chat is, do you ever use switching to alternate day steroid dosing schedule? I think some people taper just the daily dose down to off, and some people go to this alternate day schedule. So can you comment on that?
In regards to the steroids?
Yes, in regards to the steroids.
It kind of depends on the dose. I usually kind of just do daily dosing I usually keep patients on daily dosing until we're at like very, very low doses. Meaning, so, let's say we have patient 20 milligrams a day, 10 milligrams a day, even down to 5 milligrams a day, I probably keep them on daily dosing. Once we get to 5, I will sometimes taper that last little bit of steroids a little more slowly, maybe 5 every other day. The other thing to keep in mind that we've run into sometimes is, when tapering steroids, especially towards the end, 2 things to keep in mind are, 1, GVHD manifestations, but also adrenal insufficiency issues, depending on how long and how high a dose of steroids they've been on. So there are times when we do court stim tests in clinic just to kind of see what that adrenal response is. And that sometimes helps us decide whether we can more quickly taper that last part of the steroids, or do we really want to kind of go very slow, like 5 milligrams down to 4 milligrams and just taper by 1 milligram at a time.
Great, thanks, Dr. DeFilipp. I think you can take your slides down. I'll just comment. I think, some people do it as a daily taper, like you said. I think here at the Hutch, we've always tried to get people on every other day, hoping that maybe that will spare their adrenal glands, but we really don't have any evidence. There's one more question that we can deal with quickly. Do you ever switch patients to voriconazole if you're not able to taper prednisone over 4 weeks? And this will be our last question.
Yeah, that's a good question. I have typically not. I've usually kept patients on fluconazole as their antifungal agent, but I do know that there is sometimes a desire to kind of switch either to voriconazole. Sometimes I've seen patients who've met with infectious disease physicians who've preferred posaconazole and some of the other newer antifungal agents. Despite that, I don't think that we've seen a very high, I don't think we've really seen a high level of fungal infection. So in our clinical practice, I think we feel comfortable with that fluconazole choice. But once again, I don't think that there is a strong right or wrong answer in this situation.
Great. Thank you, Dr. DeFilipp. I'm just going to finish off with a few announcements, so I'll go ahead and share my screen. So just wanted to let people know that there are going to be future sessions, and in August we'll be talking about mucocutaneous chronic GVHD, and then in September there'll be a whole session devoted to sclerotic chronic GVHD. Upgoing but not yet scheduled sessions will be about bronchiolitis obliterans, the challenges of atypical manifestations, and then chronic GVHD supportive care. There's a partnership with the Meredith Cowden Foundation, and we just wanted to announce that tomorrow, actually, there's going to be a session about immunotherapy for chronic graft-versus-host disease. This is going to be presented by Dr. John Korath from the Dana-Farber. And if you'd like more information about that, then you can see the email at the bottom to get more information and to watch that. Other upcoming sessions sponsored by the Meredith Cowden Foundation will be biology of graft-versus-host disease on the road to personalized therapy and how to choose drugs for chronic GVHD.